Good afternoon, everyone. Thank you for joining us today. My name is Georgia Taylor. I'm the Project Support Officer for the Paediatric Integrated Cancer Service, and I will be acting as your moderator for the session today. I would like to begin the session by acknowledging the traditional owners of the land on which we are virtually meeting today, the Wurundjeri people, and pay my respects to elders past, present, and emerging. Today is the first of 4 sessions designed for allied health, administrative and support staff as an introduction to paediatric oncology. Today we will be hearing from Jane Templeton, clinical nurse educator at the Children's Cancer Centre at Monash Children's Hospital, who will be covering paediatric cancer in Victoria. We will then hear from Chris Williams, paediatric oncology nurse consultant, and Bob Skilton, outreach nurse at PICS, who will cover the types of children's cancer and implications for allied health professionals. A little housekeeping before we get started. We will be attending to questions at the end of the presentations. So we ask that you submit questions via the Q&A function in the lower hand of your Zoom screen rather than the chat function. However, please note that because this is an open session with staff from multiple health services attending, and we will be making this recording available online, we ask that you refrain from including any identifiable information regarding patients in your questions and try to keep questions of a general nature where possible. Today we will also be using Socrative to test your understanding of the content throughout the second half of the session. You can log in with the details on your screen now. However, we will also provide these login details later in the session, so don't worry if you don't have time to set it up now. The quiz will be made up of short answer, multiple choice, and true or false questions, and all of your answers are anonymous. Please note that these sessions are also being recorded, and you will be sent an email within the weeks after the sessions with a link to the recording as well as some post-course information and reading. Now, without further ado, I would like to welcome Jane Templeton to take us through paediatric cancer in Victoria.
Thanks, Georgia, and good afternoon, everyone. Thanks for coming along. Georgia, first slide, please. Georgia's going to do the slides for me because I can't access them from Monash. As Georgia said, my name's Jane. I work in the Children's Cancer Centre at Monash Children's Hospital. I am the nurse educator over here, but I have also worked at Royal Children's Hospital. So for those of you, you may know my face from working over there as well in the past. Okay, so let's look at childhood cancer in Victoria. Next slide, please, Georgia. On average, there's around 200 new diagnoses of paediatric malignant cancers every year. Back in 2018, there are 198 new malignant cancer diagnoses. And then last year in 2019, we had 245 Victorian children and adolescents and their families diagnosed with a new cancer diagnosis. Both Monash Children's Hospital and Royal Children's Hospital both have a children's cancer centre where the paediatric oncology patients are treated. And both of these units have nurses and doctors and some allied health staff members that work across both sites or work at individual sites. Chris will later on talk about the different types of childhood cancer that are listed there, and he'll explore that further. Next slide, please. So let's start at the beginning with Paediatric Integrated Cancer Service, or PICS. This is a term and a logo that you might see around both hospitals. There are 9 integrated cancer services in Victoria across the state. There's 3 metropolitan ICS, there's 5 regional ICS, and back when they set up the ICS, they looked at paediatric oncology and they decided to have a statewide service for paediatrics. So that's where we get the Paediatric Integrated Cancer Service from. The PICS is funded by the Victorian Department of Health and Human Services, and it leads a networked paediatric cancer system for Victoria. PICS collaborates with the Royal Children's Hospital, Monash Children's Hospital and Peter MacCallum Cancer Centre, as well as 9 regional shared care centres. They lead a network paediatric cancer system for Victoria, and they have a collaborative approach to paediatric cancer in Victoria. They aim to ensure that children and adolescents with cancer receive the best care in the best facility as close as home to possible. Next slide, please. So let's have a look at the different health services where children with cancer are treated in Victoria. First of all, we have Monash Children's Hospital. Monash is a 230-bed purpose-built children's hospital here in Clayton, Victoria. The Children's Cancer Centre, the hospital was first opened in April 2017, and it's located on site of Monash Medical Centre, but next door to it. There's also paediatric satellite sites at Dandenong and Casey, but all children with cancer are treated only at Clayton, so we'd never have inpatients across there. In the Children's Cancer Centre at Monash, we have our day oncology unit, which is known as REEF. The wards over at Monash are named after animal habitats, so day oncology is known as REEF. And here we have 12 chairs, and they can be beds as well if the patients prefer. And we're open here from 8 a.m. in the morning till 6:30 at night, Monday to Friday. We also have an inpatient ward canopy, which is adjacent to REEF. There we have 9 oncology inpatient beds in a special HEPA-filtrated pod. But we do get busy. We've had up to 25 oncology patients as inpatients at once. So we can use the beds outside the HEPA filtration if needed. Over here at Monash, we also have PICU, and we have a hospital in the home which sees patients and delivers some chemotherapy in the homes here over at Monash as well. Reef Ward, the nurse unit manager is Sharon de Graves, and she job shares with Jennifer Grant and Casey Alvin, and they work 5 days a week. And the NUM of the inpatient unit on Canopy is Anne-Marie Kilpatrick. But if you're ever after a contact person or you're not sure what to do or where to go when you come to Monash, both units have front admin desks, and the admin staff are a really good point to stop at and to talk to and find your way around navigating Monash. Just so you know that on REEF we have a daily handover of all the paediatric oncology patients coming into clinic and that are inpatients on the unit, as well as those at Monash Children's at Home, and that's at 8:45 at the REEF meeting room. But at the moment with COVID we do that via WebEx. But if you'd like to join in, you can just contact Kristen Mellett, who's our lead dietitian or lead allied health person in REEF, and she can help you connect to that. Next slide, please. So let's have a look at the Royal Children's Hospital. Yep. This is a picture of the new building, which opened in 2011, for those of you who might not have seen it before. The Royal Children's Hospital is a 334-bed hospital in Parkville in the city. They too have a day ward and an inpatient ward. Their wards over at the Royal Children's Hospital are actually named after animals. So Kookaburra is the actual inpatient ward, and that consists of 8 bone marrow transplant beds and then 18 other beds. But they get very busy over there, and where possible they put the adolescent patients on Kelpie, which is the adolescent ward, and they have 6 dedicated adolescent oncology beds on that ward. They too have a day oncology unit. They are open Monday through till Saturday, and they have 12 chairs and 3 beds over there. They also have the hospital in the home ward, which does chemotherapy in the home as well. The nurse unit manager over in Kookaburra ward is Melinda, and in the day treatment centre it's Teresa. Okay, and there's just some pictures of the units over there. Normally these days we are able to offer tours, but due to COVID we can't at the moment. But once the restrictions do lift, if you do want to come and have a tour of either unit, you can contact PICS and we can put you in contact with appropriate allied health person to take you around for a tour. Next slide, please. And then the third hospital I spoke about was Peter MacCallum Cancer Centre, which is also another new building that moved to Parkville from the city in 2016. And it's actually Australia's only public hospital that's solely dedicated to caring for people affected by cancer. They provide all our paediatric radiotherapy. They have the bunkers there at Parkville. And what we've got is a little video of a patient experience just to show you the inside of the building and what happens to patients when they're there.
Captain America is here and he is having the radiotherapy at Peter Mac.
Picked a lot of fights, but Bucky always rescued me. Wanted to be courageous and stand on my own 2 feet. I was smaller than
Captain America farts.
I could not defend until got the chance. Brand new start, injected serum.
What happens? I just wait in the kids' room. Mostly just wait watching YouTube on the iPad. One of the workers comes, then I need to go. I go in the room, just lay down, and then they get the movie ready.
I'm captain of the earth's defenders, we'll never hesitate. We fight together. Avengers behind your guys.
The symbol.
You feel the wrath of
You have to pick something up.
Never got the chance to dance with Peggy hand in hand. After all these years, she still remembers our romance. Recognize his eyes, Bucky's lost his mind, but he's still alive. I will sacrifice, make him realize that I lost a brother, lost a friend. I made a promise to defend. His mind is gone, but I will fight to bring it back again. With me, you can depend. I'll lead the way. With courage, I will venture. It's now the present day. I'm captain of the earth's defenders. We'll never hesitate. We fight
The machine just spins around and it beeps.
the wrath of life and freedom. You feel the wrath of life and freedom. You feel the wrath of life and freedom.
All I want is this actual.
One built suits and tech drones. One was highly overexposed. One is a guy that might have gone. One was an enemy long before.
If you're actually coming to this place and you see this video, don't be scared actually. It's not that bad if you actually think in your mind about it.
I'll lead the way. With courage I will venture. It's now the present day. I'm captain of the earth's defenders. We'll never hesitate. We fight together. Avengers behind your God or alien. You feel the wrath of life and freedom.
Thanks for that, Georgia. So yeah, all children in Victoria who are having radiotherapy as part of their treatment go into Peter MacCallum Cancer Centre. And patients often move between the 3 hospitals, the Royal Children's Hospital, Monash Children's Hospital and Peter Mac, with different components of their care. Okay, next slide, please. So to ensure provision of the best possible care, we hold a number of multidisciplinary or MDM meetings each week between health professionals at Royal Children's Hospital, Monash, Peter MacCallum and even sometimes Tasmania. These are medical decision-making meetings and their purpose are to make clinical decisions, develop care plans and discuss coordination of care. All newly diagnosed patients at Monash and Royal Children's Hospital sign a multidisciplinary consent form at diagnosis that consent for parents to consent to their children to be discussed at these meetings throughout the course of their treatment. In early 2020, PICS finalised delivery of a high spec video conference facility that's specifically built for these statewide MDMs in partnership with the Royal Children's Hospital and the Royal Children's Hospital Foundations. This room seats approximately 30 people around fixed tables and extra seating. The room is equipped with built-in video conference facilities, including voice tracking cameras and in-ceiling microphones. It also has a built-in microscope for pathologists and software to support the viewing of high-quality radiology and pathology results. Unfortunately, due to COVID-19, the room is currently out of use to maintain social distancing. These meetings are also video conferencing with us here at Monash, and we hold those meetings in the Reef meeting room on level 4. So we go to the next slide. The statewide MDM meetings, we've just got listed here. There's the leukaemia meeting on Mondays, the solid tumour MDM is on Wednesdays, the neuro-oncology meeting is on Wednesdays as well, but in the morning. And then we also now have the musculoskeletal MDM on Thursday, which is a monthly meeting. And as Royal Children's, they have it normally outside of COVID in that new room. And at Monash here, we have it at the Reef meeting room, but this is also done by WebEx and Zoom at the moment. Next slide, please. Over at the Royal Children's Hospital, they have what they call the comprehensive care meetings. These are the meetings that are led by the nurse consultant and the allied health staff, and they're planning meetings for nursing and allied health staff. We've just got them listed there. So for those of you who work at Royal Children's Hospital, they're the meetings that you can go to each week. Next slide, please. Over here at Monash, we have MDM psychosocial meetings as well. On Mondays, we have a MDM psychosocial education and planning meeting. We then have our MDM psychosocial meeting on Tuesday between 3 and 4. And we also have a palliative care meeting with the Victorian Paediatric Palliative Care Program that's on alternate Thursdays. We also have a journal club on alternate Thursdays here that you're welcome to join. And then we book in one-on-one family meetings as required, and the CNC's allied health team and the social workers coordinate those. Next slide, please. ANZCHOG. ANZCHOG is the multidisciplinary cooperative group of professionals who work in paediatric blood diseases and cancer here in Australia and New Zealand. It's actually free to join, and I'd encourage all of you to think about joining. Down the bottom of the screen, you can see the web page for ANZCHOG, and you can go on there and get the membership, download a membership form, and you can give it to one of the staff in the Children's Cancer Centre here at Reef or over at the Children's, and we can nominate you and co-sign you to become a member. And we, as I said, we do encourage you all to do that. ANZCHOG's vision is to ensure that all children and adolescents with cancer and associated blood diseases are provided with the highest quality evidence-based care to ensure optimal outcomes in terms of survivorship and quality of life. They also have special interest groups, which we've got listed there as well. So as I said, I encourage you to get on and get a membership form, and we will also talk about this at the end of the webinar series just to remind you how to do that. If you go to the PICS website, next slide please, it's got a wealth of information. So the website is just www.pics.org.au. There's 2 sections. There's a health professional section and a family section. If you go into the family section, and I encourage you also to encourage families to do that, but from a health professional point of view, there's some really good fact sheets and information sheets, and you can see there I've circled the medication information section. In this section here, you'll find a list of all the common chemotherapies and their side effects. They've been written, these pages have been written for parents to read, but it's a really good starting point for anyone new to paediatric oncology, or if you're just not sure of some of the side effects of drugs. The other really good resource in here is the actual introduction. Oh, can you just go back, please? Yep, is the family, What is Cancer, and the New Diagnosis book, and you'll see that up on the side of the screen, and that's a copy of the book that all families get at diagnosis. And I always encourage new staff who are new to the unit to go in and read that, because it's always a good starting point to read what the parents, the education the parents have had. It's a good base start. Next slide, please. So on the PICS website, there's also the information for health professionals. Here you'll see all the education, the face-to-face learning, the e-learning, that's all listed there. And if you want to ever book into study days, this is where you go through to. I encourage you to explore the website. As I said, the link is at the bottom of the screen there. And yeah, if you can, get on and read the patient handbook as well. Okay, next slide, please. I talked a little while ago about the regional outreach program. The regional outreach and shared care program facilitates shared care between Royal Children's Hospital, Monash Children's Hospital and our regional health services by providing education and training to the regional staff, telehealth and face-to-face regional outpatient clinics. And we now also can give some low complexity chemotherapy at agreed sites. Many of our patients, actually about a third, come from regional or rural areas, and it's really important when we are working with our families that we consider that the time it takes for them to travel and the loss of school time, family time and parent wages with coming to and from the hospitals. So coming in for treatment where possible, trying to limit that and have these patients treated out in the regional communities is what we try and do. So if possible, plan appointments or catch-ups with families when they have other appointments down at the units, and then if you can, consider time that you're meeting with the families and see if you can do it by telehealth as well. Next slide, please. And these are just all of our regional sites. You can see all the way up to Albury, across to Traralgon and across to Warrnambool, and these are the clinics that we hold around Victoria. And chemotherapy we administer at Albury, Warrnambool, Geelong, Bendigo and Shepparton. And telehealth can be organised with the patient, their GP and paediatrician at all sites. Okay, next slide, please. PICS long-term follow-up program facilitates the transition from the completion of active surveillance to the survivorship phase of care. Patients enter the long-term follow-up program 2 to 5 years post-completion of their treatment. They are then risk stratified at entry and annually according to medical needs and triaged into appropriate clinics. The triage is based on disease, current age and their current medical needs. They receive a treatment summary and a roadmap for surveillance, and then they're reviewed in clinic. Patients are generally transitioned from the long-term follow-up clinic to adult or community-based services when they complete year 12 or reach the age of 18. Next slide, please. The chart on this slide shows the disciplines who attend the clinics, and as you can see, there are many allied health professionals. The long-term follow-up program is a multidisciplinary team consisting of 8 health professionals, including oncologists, radio-oncologists, nurse consultants, dietitians, social workers, neuropsychologists, endocrinologists, and physiotherapists. They offer patients a holistic, individual, tailored survivorship care plan. If you would like to attend a clinic to better understand survivorship, please let the PICS staff know and they can make arrangements for you to attend a clinic either at Monash or the Royal Children's Hospital. Next slide, please. So just here is a book called Paediatric Psychosocial Oncology Textbook for Multidisciplinary Care. It's an ebook. We will circulate the link to this, but this is a textbook that we will be referring to through all of the 4 webinars. You'll see down there for Royal Children's Hospital, you can access it from the Royal Children's Hospital network, and from Monash with your credentials, you can also access it. But we will be sending the link out to you. And finally, it's really important that you get the chance to connect with your colleagues at other health services. It can be a great way for you to develop oncology-specific knowledge in your field. So even though we can't do tours at the moment because of COVID, please reach out and contact us or contact your colleagues at other sites and try and do some networking that way. Now on to Chris.
Georgia, can you see that okay?
Yep, can see it well.
Excellent. All right, guys, so thank you for coming to our webinar today. So my name is Chris. I work as a nurse consultant in PICS, and I also work in day cancer care 1 day a week as a bedside nurse in oncology outpatients. I'm going to talk today around the different types of childhood cancer we see and talk about some of the implications for allied health professionals. So we'll come back to this screen. We'll go through a bit of an interactive learning with Socrative a bit later. So what do we want to look at? We want to explain how, I think this is a really important thing, is really to explain how pediatric cancer differs from what most of us have an understanding of, which is adult cancer, whether that's from society, from friends, we have a bit of an idea of what cancer means in adults, but it's very important if we're going to care for this cohort that we understand how that differentiates in children. Have a bit of a chat around the differences between leukaemia, solid tumours and brain tumours in children. These are the three main disease groups. To list and briefly describe some of the tests we use to confirm a diagnosis and describe some of the likely impacts that this type of cancer may have on the child, what are their outcomes, and how that might influence you and your allied healthcare interventions. So what is it? So what is cancer? It's a disease of the cells, which are the body's basic building blocks. Australian Government Cancer Australia says it grows from abnormal cells, multiply in an abnormal way. The APON group, which is the North American group for oncology pediatric nurses, says it's also a genetic disease, that normal cells are moved along the path to malignant transformation. We know that genes and genetics and mutation is a big thing we're learning in cancer over the last 10 years. It's important to understand that cancer isn't a disease in itself. It's actually, there's over 100 types of cancers. And when you break that down with the American Brain Tumor Association, they talk about the idea that there's over 120 different types of brain cancer. So I guess the theme there is to say it is not one disease. This is very much a large group of very, very different diseases. So what are some of the comparing, contrasting between kids and adults? So the Cancer Council of Victoria, and most of us will know this, the top 5 types of cancers we see in adults: prostate, lung, bowel, breast, and melanoma. Very, very different in children. And what we see in children predominantly is leukemia. About 1/3 of everything we see. About 1/5 of everything we see is CNS tumours. About 15% of what we see is lymphoma. And then there is a large group of what we call paediatric type cancers like neuroblastoma and Wilms tumours. They're very different. We know lifestyle plays a really important fact in adult cancers: smoking, alcohol, UV light, what we eat. It's very important to understand for families who actually will try and lay some blame at their own feet that the pathways and how children develop cancer is not related to lifestyle. We do know that there is some genetic predisposition in families, and we also know that children that have undergone cancer treatment do have a higher risk of developing cancer. The treatment for cancer in adults is very distributed, because literally this is because of prevalence. It might be GP-led, oncology, regional centres, whereas in the paediatric version, because we have it's a rare type of disease, that the care is very much centralised, and it's centralised to only 2 units in Victoria, because we want to enhance what's known as the volume effect, that if you're doing something very rarely, that you have a small group of people that do it all the time. Adult cancer doesn't really have as much dedicated coordination of care, and the model is very much patient-centred. Whereas in the PEDS world, we are very well resourced from our care coordination compared to our adult colleagues, and our model of care is very much around family-centred care. We are very concerned around the later effects of growth and development, and Jane talked about that with our long-term follow-up program. It's pivotal, and it helps define how much therapy you give and what are going to be, the treatment is defined by what might happen later in life. There's a lot of difficulties around adolescents and how do we transition them. When we look at the adult world, 68% of adults that develop cancer will be alive after 5 years. And in the pediatric world, it's about 84%. So those numbers are much better, but it's really around morbidities as well. A lot of those numbers in adults are very old people with comorbidities. About 99.3% of all the cancer we see in Australia is in the adult world, and about 85% of all the clinical trials that happen in the adult. However, only 0.7% of all cancers we see are in children under 15, but I think we really punch above our weight with clinical trials. About 15% of all the clinical trials we see in Australia are from that small cohort of children. This is a big number. It's estimated about 150,000 new diagnoses of cancer in adults in Australia this year, and we're only seeing around about 800 new diagnoses in children under 15. So should we call cancer a rare disease in children? 800 kids a year. This is some older data. It is over 10 years old, but what it looked at is from the Australian Institute of Health and Welfare, and it looked at hospitalisation rates for children between 0 and 14 for chronic diseases. So this isn't talking about children that come in for their tonsils out or a child that broke their arm, but when we look at the major chronic diseases, reasons for coming to hospital, we see that cancer is the most second prevalent reason for why a child would present to a hospital and be admitted. Cancer is also one of the leading causes of death and chronic disease across children as well. So it really is rare, but we know that within hospital situations, for those of us that work in tertiary hospitals, they're full of children with cancer. They're very, very busy. They consume a lot of time in outpatient and inpatient departments. So it's really important that we have an understanding of that. If you go to the Australian Childhood Cancer Registry, which is on Cancer Council Queensland's website, you can actually look at some really good data across Australia for incidence of cancer. You can see there that almost 800 children under 0 to 15. We see that the prevalence is actually a little bit more between boys than girls, and that the most common age for childhood cancer between 0 and 15 is in that 0 to 4 years age group, 0 to 4. And a lot of that's because of leukaemia, which is our most common cancer we'll see. Relative survival curves, if we look at the percentage of children alive after 5 years, you can see that from the last 20 to 30 years, that has come up considerably. And overall now, about 83 to 84% of children will survive their disease and still be alive after 5 years. So what are the types? So childhood cancer generally comes under 3 distinct streams, the way that most cancer centres will manage it: the leukaemia or liquid stream, the solid tumour stream, and the CNS or neuro-oncology stream. Bone marrow transplant also has a dedicated team at the Royal Children's, but it's a treatment modality and not a disease. So the first one is liquids. It's predominantly leukaemia, and leukaemia is what's known as a disease of the blood forming components or the blood factory. Leukaemia is the most prevalent childhood cancer, and about 1/3 of all cases we see are from acute leukemia. This is a hematopoietic stem cell. A lot of nurses that we teach around leukemia need to understand this, and this is the way our cells in our bone marrow grow and become mature, and they go out into the bone marrow, they go out into peripheral circulation. And when they grow up, they become neutrophils, white cells, red cells, platelets, and things like that. Leukemia occurs when they are very, very young, and what we call blast cells, or lymphoblasts and myeloblasts. And when these cells are very, very young, for some reason in children with leukemia, that cell mutates, and that tiny little immature cell starts to replicate rapidly, and then it goes out of the marrow into the peripheral circulation and doesn't grow up. And so what we have is a scenario of AML, is when children have blast cells that are on the myeloblast line, and ALL, or acute lymphoblastic leukemia, when children have a cancer that is seen under the microscope on the lymphoblast line. And so this is language, ALL, AML, are kind of those acronyms that families will use quite a lot. So acute leukemia ends up going out into the peripheral circulation, and there's this uncontrolled growth of these partially developed white cells or baby cells or blast cells. And they start to build up in the blood, they build up in the organs. And this is where we get that presentation of a picture of a child that might be have pallor and have fever and be neutropenic and present, and we get a diagnosis of leukemia. So what does the treatment plan look like for acute lymphoblastic leukemia? It's generally about 2 to 3 years of treatment. We have an induction period where it's very important to understand children initially diagnosed are at high risk of sepsis and getting very, very unwell. Then there's a period of consolidation and interim maintenance, and then we ramp that therapy up again a few months down the track. So there's these 2 time points during their treatment where they're very high risk of developing sepsis. And that's an important thing for the families to know, that we have them rapidly back into the hospital if that's need be. And then for both girls and boys, they have about 2 years of therapy, which is known as maintenance therapy. This is predominantly all outpatient-based therapy. Much of that maintenance can happen in regional centres, and some of our regional colleagues will provide that therapy for us. And during that whole time, they will have a central line or a port for their therapy to go through. Overall survival for acute lymphoblastic leukemia across all risk types is around 92%. For those very good risk types with good genetics and good response to treatment, good age and all those nice things we like to see, the overall survival rate is close to 98% to 100%. Contrasting that with the other type of leukemia, so ALL, acute lymphoblastic leukemia, lymphoblasts going out of control, AML, acute myeloid leukemia, where the myeloid blasts are growing out of control as baby cells. The standard treatment for AML is 4 cycles of very high intense therapy, where children are very low immunity, high risk of sepsis. And so for much of this therapy, they'll be inpatients. The 4 cycles of therapy generally last between 4 to 6 months, depending on how they're going with it. It's all IV chemotherapy. They'll get what's known as a Hickman line, and we'll talk about that in future sessions, which is an external catheter that comes out. And for those where that doesn't work well, they will progress to a bone marrow transplant. You can see on the data here, the overall survival for AML on the most recent published studies is only about 62%, which is much worse than we'd see in the ALL group. So AML is a much harder disease to treat. What is the worst prognostic factor? When the children have their first cycle of induction, we know that at the end of that induction, they'll be tested for a test to see how much disease they've got. If they've still got a lot of positive disease, it's a very poor prognosis. And so nearly all of those children will proceed to a transplant. So what's the implications if you work in allied health? It's a challenge for us because allied health is such a diverse group, but we try and at least get these some areas where we know you will have involvement. So leukemia from a nutrition point of view, we have frequent issues with weight gain during and particularly after ALL treatment. Children that have leukemia or ALL will be on a lot of steroids. They'll have an insatiable appetite. Having an insatiable appetite for a long period of time develops bad habits. And we see a lot of obesity and weight gain off treatment, particularly in the girls, in survivorship. So it's a real challenge in late effects to maintain a healthy body weight, because as having a history of cancer, we want to reduce our other risks of developing adult-like diseases. So having good body weight is important. So nutrition is always important. And having said that, we still will have issues during those high-risk periods of treatment where they may need nasogastric feeding, and it's not uncommon to see weight loss during that therapy. Physical functioning, so peripheral neuropathy or pins and needles and poor function of the feet and sometimes the hands can happen from long-term vincristine. Up to almost 1 in 5 patients will experience this. Vincristine is one of those chemotherapies they get a lot. So a lot of physiotherapy referrals for nearly all children that are treated for ALL. Psychosocial issues, such as family, school separation, particularly regional kids, procedural pain issues, and particularly issues of adherence to long-term treatment. And that's a real issue for adolescents as well. If you have ALL and you're having 3 years of treatment, it's 3 years of medicines at night that have to be given time after again and again. We know that the risk of relapse increases if that adherence to long-term treatment sits somewhere below 95%. That's a really high number. So there's a lot of social factors that can actually impact on that kind of thing. And from an education point of view, we know that children with leukemia will get what we call CNS-directed therapy, which means we need to give them a lumbar puncture or a spinal tap, and chemo goes into their spinal fluid, and that's part of treating that area of their body. And because of that, they can develop what's neurocognitive morbidity, so education and learning as they grow older. So it's important we involve psycho-oncology and different people to support them. The second disease group or group of tumours we have is the solid tumours, a very diverse group. As I said, there's not one disease. This is a group of very, very different tumours, and some only occur in children. In paediatrics, often the solid tumours are generally described by their cell line rather than location. So for example, they wouldn't be called a bone cancer. My child has osteosarcoma. So it's really around the cell line itself. So sometimes the language you'll hear is a little bit different than in adults, where it might be lung cancer or prostate cancer. Solid tumours often require multimodal therapy, such as surgery, chemotherapy, and radiation, like Jane talked about at Peter Mac. And most solid tumours are based on the concept of staging, which most of us are aware of, particularly from the adult world. And that usually correlates with outcomes. So stage 1, very favourable, up to stage 4, very unfavourable. So it's an important thing when you're listening to handovers or reading some case notes about a patient to know that a patient with a stage 4 disease, from a psychosocial point of view, from an outcome point of view, from the amount of toxicity and treatment, is going to be much worse than a child that has a stage 1 tumour. Nearly all children will have a central line because nearly all of these children are going to require some version of chemotherapy. and most treatment compared to the ALL group is usually less than 12 months. So this is the distribution of solid tumours we see, all reported solid tumours. Solid tumours that get reported to the cancer registry database can be something as simple as a cancerous appendix that had resection and wasn't treated. So there's this large group, purple group, of quarter of all the diseases, which nearly all of these diseases we will not see in the cancer centre. I'm going to focus on a few of those diseases we see more commonly, and we'll have a chat about some of those. So osteosarcoma or Ewing sarcoma are the bone cancers. They're the two main groups of bone cancers we see. This is often much a disease of older children and adolescents, and particularly young adults. Osteosarcoma and Ewing sarcoma are diagnosed via surgical biopsy. Children will get MRIs for diagnosis, and this treatment is very multimodal. Ewing sarcoma patients will get radiation. They'll all get chemotherapy and surgery. Outcomes vary according to staging. So osteosarcoma and bone sarcomas, outcomes are much better if they have localized disease, for example, in the distal femur, as opposed to in the distal femur and in the lung. So again, an important thing for you to look at in case notes when you're looking at solid tumors, are they metastatic? Because metastatic disease, you can see there is much worse outcomes than those with localized disease. Rhabdomyosarcoma is a second group of solid tumours we see, and these are tumours of rhabdomyo, which is like malignant tumours of skeletal muscle. They are all staged, so you'll get a stage 1, stage 2, stage 3, stage 4. Majority of these are very, very little children. This is incredibly rare in older patients and in adults. Again, biopsies are a standard of care for diagnosis and different kinds of scans, PET scans, CT scans. Treatment's very multimodal, so they will be over at Peter Mac, they'll have central lines for their therapy. And again, it's important for us to understand staging. Stage 1 might be as great as 90%, to poor genetics in stage 4 could be as low as 15%. That's a wide variance for one disease group. So it's important we learn a little bit more about the patient, their family, and just the diagnosis, but we need to know the staging. Do they have metastases? The third group are neuroblastoma, neuro being sympathetic nervous system. This is a tumour that can move along anywhere in the sympathetic nervous system, but generally arises around the adrenal glands as a big swelling in the belly. Majority of these patients are very little. It's very much what we know as an embryonal tumour, a very young age to get this disease. Again, biopsies, bone scans, bone marrow aspirates, MIBG scans, a lot of workup before we get a definitive diagnosis. The stage 4 treatment or metastasis treatment is what we generally see in the hospital situation. The early stages are generally resected and we don't see a lot of therapy. And so most patients you're going to see with neuroblastoma are those with stage 4. Interestingly, this is a disease where some infants may not even require treatment. If they have good genetics and they have some disease, it actually can go away by itself if they're under 18 months, and it might just be observation only. So a very weird kind of disease. Renal tumours is the fourth group. Renal tumours predominantly are known as Wilms tumours. These are the kind of language and words we get used to in caring for families with children with these types of cancers. The majority, again, this is an embryonal tumour, so the majority of these children are very little. Ultrasounds, biopsies, most often they'll get either a nephrectomy or a partial nephrectomy to cut the disease out of where it is in the kidney, and then follow that up with periods of radiation and chemo depending on their staging. This is a very highly curable disease, and there's an overall survival rate of over 85% for all stages. However, some children will still succumb to that disease. And then there are the two types of lymphoma groups, Hodgkin lymphoma. Hodgkin lymphoma is really a progressive enlargement of lymph nodes due to malignant cells moving around. And it's very much a disease of older children. We don't really see this in little children, and it's more seen in the adolescent and young adult patient group. It's generally a much more slower onset than the non-Hodgkin lymphoma, and staged. We've got bloods, biopsies, and PET scans. Again, a lot of work going into before we get a definitive diagnosis. Most of the treatment's multi-agent with chemotherapy. It generally means long day outpatient therapy. They generally don't need to be in hospital for this. It's outpatient-based therapy with us in day cancer care or down in Reef at Monash. And that can go from a few months to several months. Most children with Hodgkin lymphoma are cured of their disease, and the outcomes are very favourable. The non-Hodgkin disease is really much solid tumours that are characterised by undifferentiated lymphoid cells, and this disease is a little bit more systemic than the Hodgkin's, can be very localised. The incidence increases into young adulthood as well, so it is again a disease more of older children, adolescents and young adults, and it's all staged and diagnosed in very similar ways to Hodgkin lymphoma. The treatment is very much primarily chemotherapy. However, some subtypes may have treatment that's almost like ALL treatment that might go for years. So you might be looking after children with non-Hodgkin lymphoma that have 6 months of treatment or 3 years of treatment, depending on what subgroup they have. And again, the outcomes are very favourable of 80 to 90%, but the prognosis in relapse with non-Hodgkin lymphoma can be very poor. And right now we are doing some new treatment options, including the consideration of what's known as CAR T-cell therapy and immunotherapies for children that relapse from non-Hodgkin. So what are the implications if you work in allied health and you are caring for a child with solid tumours, or what might you be referred for? Malnutrition as a result of disease and treatment is seen in almost half of patients with solid tumours. So referral to nutrition is really mandated. I feel it should be mandated, and the health services would recommend that we refer to nutrition for all children that are newly diagnosed with solid tumours, really just to have a look at how they're travelling, do they have any premorbid, any other comorbidities, and then we can revisit that during treatment. In fact, weight loss is actually a staging tool in lymphoma, so high degree of weight loss is part of the routine of the disease process. And many solid tumour patients will require enteral feeding, particularly rhabdomyosarcoma will all get nasogastric tubes. Those children with bone sarcomas like the osteosarcoma will nearly always need a nasogastric tube, and many will actually have PEG tubes inserted for their nutritional needs as well. Because of the solid tumours itself, there's a real demand for physical functioning, so a lot of rehabilitation is not uncommon. Referrals to rehab, particularly where surgery has been quite a large impact on their major treatment modality, and particularly in the musculoskeletal system. So where we've had solid tumours with bone, amputation, muscle, and corrective surgeries, will have a lot of physio support. As opposed to the leukemia group, there's a lot more management of pain in the solid tumours, really because of the nature of the disease. So chronic pain, acute pain can be a real issue, and procedural pain. So for example, Wilms tumour patients where there's an average age of 3 or 4 may need weekly accesses of their port, of their central line for maybe 6 months. That can be a real procedural pain issue, and we have a lot of psychosocial support to manage that for those children and their families. And then there's the altered body image as well, which can come with solid tumours, corrective surgeries that we need to be mindful of. Result of having multimodal therapies, radiation, chemotherapy, surgery means there's a lot of time off school. So it's really important that we involve education upfront and very early to support them, particularly for critical time points during their schooling. If you compare that to leukemia, for example, the 2 years of maintenance they're on, they'll be at school most days for that. And the third and final subgroup is the CNS or central nervous system tumours, also known as the neuro-oncology team. So a CNS tumour is literally just a tumour located anywhere within the brain or the spinal cord. This is the most common solid tumour type in children, up to a quarter of all childhood cancers. Again, it's very important we don't just roll them all up into one group. There are many different types of solid tumours, different types of brain tumours in this group. What's important to recognise is they are the most common cause of cancer-related morbidity and mortality, the most common cause of significant late effects. So we actually have dedicated neuro-oncology clinics in late effects for this cohort of children. Little is known about the cause of solid tumours, of CNS tumours. We do know it's not from radiation and listening to mobile phones. We do know there are some associated genetic predispositions as we learn more about this information. You can see here it's a challenge for a neuro-oncologist because there's not one type of disease, and every one of these tumour types on this group here have a very, very different way of managing them. The ones I've highlighted there are more what we would see, and it's not to learn about them, but to be aware for you guys in a group to these words. So medulloblastoma, ATRT, we love to put acronyms on everything, atypical teratoid rhabdoid tumours, Pilocytic astrocytoma. So low-grade gliomas are the most common brain tumor we see. About half of all we see are low-grade gliomas, and most of those are pilocytic astrocytomas. Ependymoma and diffuse midline gliomas. So these are some of the words and language we use. At least one child is diagnosed with a CNS tumour every week in Victoria. But what's important to understand is 30% of the CNS diagnoses that occur, on average, only occur 1 to 3 times per year. So it's a real challenge in finding effective therapies, clinical trials, because they are such rare diseases. There's often delays to diagnosis, and they're not uncommon. Presentation can take weeks to months with brain tumours, highest association of delays. However, the rapid time to diagnosis, someone that occurs very, very quickly, is often associated with aggressive high-grade tumours. The gold standard is via an MRI. That's the #1 way of getting an initial diagnosis, and then for nearly all tumours, an analysis of the tumour biopsy. So they'll need some level of surgery. Not all children have complete resection, but they'll need at least a biopsy up front. The treatment intent for CNS tumours is always cure or control of disease with preservation of function. There are some types of brain tumours, some types of high-grade gliomas where there is no cure, and so that treatment intent will be more palliative. Surgery and what we know as gross total resection, which is taking the entire tumour, balancing that without adverse sequelae or adverse late effects, is often the ideal in treatment. And because of that, most of the brain tumours we see from the inpatient ward, Kookaburra, Reef and day cancer care, we don't see a lot of these children because their treatment is from surgery or radiation alone. Chemotherapy has a place in some CNS tumours. For medulloblastoma, it's probably the most common one we would see for inpatient therapy, and for the low-grade gliomas, we may see some of those in the outpatient setting. As I said, some CNS tumour types unfortunately do not have a curative treatment plan at diagnosis. These include diffuse midline gliomas and much more of the high-grade glioma types. And on this slide, it's a bit of an idea, as I said, when we meet a family with a cancer diagnosis and you're providing what allied healthcare supported within your expertise, it's good to understand where they're at. And from a CNS tumour point of view, what this slide shows is from North America. It looked at a large group of kids, about 700 to 800 children that had died from CNS tumours. And what it broke up here on the left side of the screen here is what type of tumour they had. You can see there that high-grade gliomas accounted for almost half the deaths in children. Remember I said to you earlier that the low-grade glioma group or the polycytic astrocytoma group account for about half of the disease we see in CNS tumours, but you can see by this graph they only account for about 3% of the deaths we see. And the one on the right is showing where was the location of the tumour itself. And you can see here that almost 40% of the tumours of the brainstem resulted in death. And so if a child has a brainstem tumour that is a high-grade glioma, that is an awful prognosis. So it's important to understand some of the where they're from, what the tumour type is, to give you an idea of possibly where that family and that child is heading in their care. And I've talked briefly, but survivorship is critical in any child that has a CNS tumour, has had resection, has had radiation. Survivors are at high risk of late effects, and they all experience, or most of them will experience, poorer health-related quality of life than their healthy comparators, such as brothers and sisters, but also compared to all other childhood cancer survivors as a group. The neurocognitive and the neuropsychological consequences of treatment, the increased risk of neurovascular disease and stroke, impaired motor skills, secondary cancers, and endocrinopathies demand a real tailored and multidisciplinary approach to caring for this group. You can see here on this screen, these are modelled IQ scores of children that may have had low-grade glioma that required radiation therapy. And you can see here how the younger you are, the more chance that you're going to suffer from a much poorer IQ after 5 years of treatment. The older you get, so the 12 and above, your IQ score is not going to really fall. And so this is an important thing we think about when we're looking after children. If you're an educator or you're a psychologist and you've got a child who has had radiation for a brain tumour, the big question is how old were they when they had the radiation? If they were 5 years old when they had their cranial spinal radiation, they're at high risk of education and cognitive issues, and they need a lot of intervention. If they were 13 or 14, they may not have as much a higher risk. So what are the implications for allied health? Nutrition, again, is a real issue. Weight loss from therapy, particularly those therapies requiring chemotherapy, radiation, and surgery. For those that have metabolic issues, it can be intractable weight gain as an issue of endocrine issues from CNS tumours. So they all need a good nutritional consultation, and they will all get a nutrition consultation in late effects as well. These are children that won't leave, as much as they leave the cancer service, they don't leave the care of paediatric care right through their childhood, because we need to ensure they're growing well. Many children with brain tumours will have a gross and fine motor skills, depending on the surgery they had. They may have an impact on that, and they may need some rehabilitation. So many children will be referred to rehab, and that often happens around the times of surgery. There's a lot of psychosocial impact, and there's this concept of double impact loss. So this is the idea that a child with leukemia, the family are dealing with a cancer diagnosis, but what they're looking at with a child with a brain tumour, we're dealing with a cancer diagnosis and some kind of loss of functioning. They may have poor social functioning, poor cognition as a result of the tumour. And so it's this double impact of losing two things, the cancer diagnosis and some type of functioning that may not ever come back. And CNS tumours are associated with the highest mortality and morbidity. So from a psychosocial point of view, it's critical we provide quality care. And education for educators, for neuropsychology, 40 to 100% in studies of CNS tumour survivors will experience some degree of neurocognitive morbidity. So early intervention into learning programs and support is critical. Right, we're going to take a quiz break, Georgia. If you can take over, I'm going to leave that screen there for a sec. If everyone wants to whip out their mobile phones and go to socrative.com and enter that room name, Williams 5291. If everyone has a chance, so that's socrative.com. If you haven't had an opportunity to get on, I'll give us another minute before we get into it, and have a look on your phone. We can see there we've got about 9 people on. If you want to dive in, otherwise we can work alongside these guys that are already on. So socrative.com, you enter as a student and your login is Williams 5291. All right, so that's good. We've got about half our guys on, so we might get a start. So let's have a look here. The types and incidence of cancer seen in children are very distinct from adults. Georgia, you want to give us the results? That's true. I think it's an important thing to understand, that what we're seeing in the childhood space is very, very different than we see in the adult space, including the models of care. Very, very different. We're very much around family-centered care, and our outcomes are much better. Next question, Georgia. So the 2 most common cancers seen in children. Okay, how'd we do? Lovely. So leukemia and CNS tumours. So if you work in this area, if you are around a lot of these families, particularly outpatient as well as inpatient, the inpatient group will have a lot more of the rarer tumour solid types that are in the ward a lot. But if you work as a whole and get referrals from oncology services, both on and off treatment, and you would want to know a lot about this, if you learn a lot about leukemia and brain tumours, you're literally covering almost half of all the cancers we'll see. Next question. The 5-year overall survival rate for childhood cancer in Australia. If we can hide those answers, Georgia, and we'll see what happens after. Yeah. Okay, let's have a look. A little varied, but it's around about, most of you got it about right, 83 to 84% So that's currently right now, 83 to 84% of all children will survive their disease. Very different if you think about your year of birth. And I don't want anyone to post that right now, but if you were born in the early 1970s and you were a 6-year-old girl and you had a good response to treatment for leukemia, you still only had about a 10 to 15% chance of surviving. If you're the same child today, you've got about a 98% chance of surviving. So we've really gone ahead in leaps and bounds in paediatric cancer care in the last 40 years. But today, as we speak, overall, that's brains and solids and leukemia and high risk and low risk all put together, it's around about 83% overall. Next question. So which age group, the highest incidence of cancer occurs in which age group that we deal with in the 0 to 15s? Let's have a look, Georgia. Cool. And so, as I said, that's predominantly because of leukemia being the most common disease we see, and that nearly always occurs in that younger group. It's a high prevalence rate in very little children. In fact, the 0 to 1 year is actually a very rare type of age group. It's really that 2 to 4, but that is a thing to think about when we're thinking about planning care, looking after children that are so young. Yep, next question. The 3 main disease streams that we have in childhood cancer. And so this is thinking about how we provide that care from a hospital setting and how we break it down. Let's have a look, Georgia. Yeah, so liquids, solids, neuro-oncology, or CNS tumours, solids, liquids, and brain tumours. And that's kind of like many allied health, social work, nutrition may actually go into one of those areas, or even BMT, where we actually have a dedicated person. So if you are caring for a child with a brain tumour, you can actually look up their notes, or you can contact the hospital and there may be a dedicated allied health for that person as well. Next group. Current treatment for acute lymphoblastic leukemia in children lasts how long? Okay, let's have a look. Yeah, it's about 2 to 3 years. I put in, there used to be this idea up until a couple of years ago where boys actually used to get a year longer than the girls. And we found that in the studies that really didn't help. And so we were just giving an extra year for no real reason at all. And so now it's about 2 to 3 years in total. And that's something to think about from a long-term point of view of, you know, is cancer an acute disease? Or if you're on treatment for 3 years and surveillance for 5, it's really becoming a chronic illness. Next one. Is this true? AML has much better outcomes than ALL, acute lymphoblastic leukemia in children. Let's have a look. So it is false. AML is a much worse outcome. So about 62% of all children that get AML will survive their disease, and around about 92% of children that get ALL will survive their disease. And so that's an important thing to differentiate from, because they're very different treatments. The AML treatment is very toxic and has a lot of side effects and needs a lot more allied health referrals. Next question. Generally, high stage solid tumours will have a poor prognosis than low stage tumours. Let's have a look, Georgia. Yes, that's true. And I think this is something to think about. Again, it's not hard to look those things up. But if you see a child solid tumour with a stage 4 something, then you know they're getting high therapy, more modalities, maybe radiation. They're going to be probably more sicker from it. And even through all that, their outcomes are probably going to be poorer. So that's something you need to look for, not just the name of the disease. Yeah, next. Which cancer group is associated with the highest rates of mortality in children? Let's have a look. Yep, the CNS tumour. I often call this like the poor cousins of the leukemia group. And I say that because the face of children with leukemia, they're there for 3 years. They become residents of the cancer centre. Everyone knows them quite well. They get a lot of chemo and they're in and out. Many children with brain tumours actually have resections, have a bit of radiation, and may never be admitted to Kookaburra ward or go to Reef that often. And that means we don't see them enough, but that their outcomes are poorer, the morbidity is poorer, and they really actually need that really high degree of input compared to leukemia group. Next group. And finally, the highest rate of mortality in CNS tumours is in which area? Okay, let's have a look. Yes, so high-grade gliomas, it's good we're learning that. So if you have looking after a patient with a high-grade gliomas, it's a large group of tumours that really have poor outcomes for many of them. And if they have it in their brainstem, a high-grade glioma of the brainstem is one of those palliative approaches. And so I sometimes think it's important that you can break down the CNS tumour a little bit. Many low-grade gliomas that are completely resected have fantastic 100% outcomes compared to that, which can be very, very poor. All right, I think that completes our bit. I think, Georgia, we're going to open some questions, but I'll hand it back over to you to take controls.
I can see we haven't had any questions come through just yet, but we might just leave it a moment to allow people to put anything in. Just a reminder with those questions to only include non-identifiable information, and we'll do our best to answer those. While we're waiting just to see if any come through, I will just remind everyone that our second session, which will be covered by Chris, is next Friday the 16th from 12:30 to 1:30, and we will be talking about the side effects of treatment. If you aren't able to make any of the sessions, so either the one next week or the 2 in the weeks following, we will be recording each of the sessions and sending those out directly to everybody who registers via Zoom, as well as making those available on our website. I can see we've just had a comment come through. Great job, Jane and Chris. Well presented, thank you. There aren't any questions, so I'm going to take that as a sign that we have really covered everything, or we've just had one come through in the chat. Do you know of any specific studies that have looked at intervention to support improved speech, language, and communication outcomes in children with ALL who are accessing treatment in the early years?
I would say not in the ALL space, but there's certainly been, and I can probably find some of this if you want. I've seen some presentation at conferences a couple of years ago around interventions in speech and different ways of trying to improve speech path in the brain tumour population. And maybe if I can find that, I'll forward it to Georgia, and whoever sent that, I can forward that on to you. I know there was a poster presentation on it, and there was an intervention to try and improve it. I remember watching some video they presented, which was incredible to see a child go from incredibly poor speech from a cerebral mutation to amazing effects. So if I can find it, I'll get it to Georgia.
All right, we haven't had any other questions come through. If there is anything that you think of between now and when we send out the post-course information, please don't hesitate to get in touch with our presenters or to email the PICS email address, which is pics.admin@rch.org.au, and we can refer your questions onto the correct person. On that as well, feel free to contact the PICS team or our presenters at any time after these presentations if there is anything in particular you want to get involved with, if you want to come along to a meeting, or as Jane said, if you want to have a tour of any of the wards at RCH or Monash. I can see that that's it and there's no other questions, so we will wrap up a little early. Again, thank you, Chris and Jane, for your presentations. From the lack of questions, we can see that obviously they were very informative, and we will be in touch within the next couple of weeks. We will send out the presentations in a PDF format, as well as all of the post-course information. Thank you everyone for attending, and have a great day.
Thank you very much.